Welcome to Learn at Work, a webinar series presented by Work, a journal of prevention, assessment, and rehabilitation, published by iOS Press. I'm Karen Jacobs, the moderator and the founding editor of Work, a journal of prevention, assessment, and rehabilitation. I'm delighted today to have two people coming to speak about an article published in Work. Julie and Rawan will introduce themselves and also talk about their study, the Work-It study for people with arthritis, study protocol, and baseline sample characteristics. Welcome, Julie and Rawan.
Hello, Karen.
Thank you, Karen.
And thank you for inviting us. We are very pleased that our work was published in Work, and we are happy to be here today to discuss the study. So I am Dr. Julie Keysor, and I am an associate professor in the Department of Physical Therapy and Athletic Training at Boston University, as well as the School of Medicine at Boston University. And I'm director of the Center for Enhancing Activity and Participation among people with arthritis, or ENACT, and that is funded by the National Institute on Independent Living and Disability Research. And I will now let Rawan introduce herself.
Yeah, thank you, Karen, for this opportunity to speak to this audience. Whereas I want to echo what Julie said, we're very pleased that our manuscript was published in Work. And my name is Dr. Rawan Alheresh, and I am an occupational therapist by background, and I have a PhD in rehabilitation sciences. I currently work as a postdoctoral associate in the Health and Disability Research Institute in the School of Public Health in Boston University, and I also am a visiting scientist at Tufts University in the occupational therapy department. Yeah.
Excellent. All right, thank you, Rawan. Rawan's going to start our talk, and then I will finish up. She's going to do the first half, and I will do the second half.
Sure. So in the beginning, I'm going to discuss the impact that arthritis and rheumatological conditions have on employment, and give you an idea about some statistics of the issues of in terms of the prevalence of the disease, and work disability as an issue for these for populations with arthritis and rheumatic conditions. And then I will go into detail in describing some of the approaches that have been shown to be evidence-based to reduce limitations in the workplace and to help people in work disability to sustain their employment. And then, yeah, so in the beginning, let me just give you an overview of what arthritis is. Arthritis is a term that refers to more than 100 different rheumatic conditions. And the thing that joins all of these conditions is that they all affect the joints somehow and the tissues that are surrounded by them. And it also affects the connective tissue and the region of where the joint has certain inflammations and problems. And what, as I said, and what joins these 100 rheumatic conditions under one umbrella is that all of the people who have these suffer from pain, and they suffer from joint stiffness, and they suffer from limitations in doing their activities. And they are also limited in participation in their life roles. And the most common types of arthritis are osteoarthritis, which is the most prevalent type, and that is followed by fibromyalgia and rheumatoid arthritis. And there are other less prevalent conditions, but they are more serious and more severe, such as lupus and Gouty's arthritis and psoriatic arthritis. There are different types of arthritis, such as ankylosing spondylitis, juvenile arthritis, and many more that you can encounter. But as we said before, they all have some similarities in which they have joint pain, they have stiffness, and they share limitations in participation. And when we're speaking about the United States, more than 50 million people have doctor-diagnosed arthritis. And although we always think of arthritis as a condition that only happens to people who are older, it actually affects people of all ages and affects both genders and all ethnicities. And I just want to emphasize that people with arthritis experience pain and joint stiffness, and they do experience activity limitation and participation restriction. And because of that, it's considered the leading cause of disability in the US. As you can see here in the chart, arthritis is the highest condition that causes to people being disabled in different parts of their life. And this is just another idea to show you that from these 52 million people who have doctor-diagnosed self-reported arthritis, you can see the hierarchy go up, and about 8 million people and more are limited in their workplace. So you can have people that have participation restrictions in multiple areas of life, but over 8 million people of these 52 million people experience limitations in the workplace. And it is considered a growing problem here in the United States. As you know, the population here is aging, and it is expected by the year 2025 that 63 million people will have arthritis. And as you can imagine, the number of that, since it's increasing, the prevalence of participation restrictions will also increase. So why should we be concerned about work as an area of participation? So when we think about arthritis, it's not just a condition that has mild pain among people who are older. As I said, it affects people from all ages. And when we think about arthritis, the onset of arthritis is usually between the years of 35 and 50 years of age, which is the years that the person tries to have the maximum growth within their careers. So it's not only a disease to people who are older, but it's also for people who are going through their midlife career phase. So about 5% of employment aged adults aged 18 to 64, which is approximately 7 million people, they report a limitation somehow in their workplace due to their arthritis or their rheumatological condition. And in a previous survey conducted by the CDC, approximately 30% of the US population reported being unable to work or limited in some type of work or the amount of work due to their arthritis. And between 23 to 45% of people with arthritis become unemployed within 10 years of being diagnosed. And that just, gives us, an idea of the difficulties that people face, that they have to drop out from their work earlier because of their health condition. And this is true. This has been studied for many arthritic conditions, and one of them is rheumatoid arthritis, which has the most drop out from work because of that condition. That also has been studied in psoriatic arthritis and ankylosing spondylitis and in lupus. There are some other considerations that we should think about when we tackle the issue of limitations in the workplace and work disability, where people drop out from their work, is that people who have arthritis and workers with arthritis in general are concerned of disclosing their disease to their employers. And that is one let's say, issue that is constantly coming up in different research studies and in different encounters with populations who have arthritis when we talk about employment. And unfortunately, worksite programs to assist these people are not widely available. And when we're talking about work-related disability, usually this isn't also addressed in patient-provider consultations either. So when it comes to risk factors for arthritis work disability, and they're divided into two major parts. The first one is disease-related, which is the duration that the person has the disease. So in some studies, some researchers found that the longer the duration is, the higher the risk factor to be work disabled. And the severity of the condition, the pain levels, the fatigue levels, and the person's physical functional status. These are all disease-related risk factors for arthritis when it comes to predicting how a person will have work disability in the future. And there are some other risk factors that we are, as researchers, interested in. They are work-related, which includes the job demands and the support from co-workers. And these are things that we can intervene as rehabilitation professionals to assist people maintain their work status for longer. So this leads me to the second portion of the part that I will be speaking to you, which is discussing effective approaches. So we know that medical treatment has been very, let's say, I wouldn't use the word successful because you can't treat arthritis, but you can reduce the symptoms. And there has been multiple treatments and studies to help people with arthritis. And beginning in the 2000s and onwards, there's been the introduction of biologics and different treatments for arthritis that help people manage their symptoms to a great extent, in which you can begin to see a huge improvement on their pain and stiffness levels and their participation levels. But up until this moment, people still consider work disability to be one of those factors that still need improving upon. And in the US Health and Retirement Survey, there has been a use of a wide variety of job accommodations to extend employment tenure to help people remain employed for longer periods. And when job accommodations were used, it increased the length of time between the onset of work, of the work-limiting condition, which is arthritis here, and the application of the person for disability pensions and reimbursements from governments and the Departments of Health. And we can, and about 63% of employed persons with rheumatic conditions reported that they needed job accommodations in some previous studies by Sara and Alheresh. And few employed persons with rheumatic conditions actually do receive their job accommodations. So you can see that there's a need to introducing accommodations in the workplace, because people do say that they want them, but that unfortunately they aren't widely available for them. So the reason for the scant use of job accommodations as we know it now is that individuals themselves who have the rheumatic conditions and who have the difficulties at work, they are the ones that have to initiate the job accommodation process. And in order for someone to do that, they must be fully aware of how the procedure happens. And unfortunately, these people may not be fully aware of how their health condition impacts their work activities. And they also may not be aware of the resources that are available for them. And they don't even know that they should move forward and ask for these accommodations, because they don't have any idea that it's available readily for them. And many of them are not even aware of the job accommodations, of how to access them, as I said. So having these services ready for them and telling them that they are available for them would help people to move forward and ask for them in the future. So one of the effective approaches that has been studied in the past is the use of vocational rehabilitation. And this helps people explore and secure job accommodations, and it helps people advocate for their rights. So here you can inform the person who has arthritis that it is their right to ask for accommodations, and you kind of inform them of the legal aspects of what they're eligible for under law. And using vocational rehabilitation also helps us educate people on the available policies for them and the resources that they can tap into to help them with their work status. So knowing that, in the early 2000s, Dr. Sara Alheresh, she conducted a job retention vocational rehabilitation program for employed persons with arthritis, where she studied this intervention that I will mention in a bit, on 242 employed individuals in the United States who had a rheumatological condition. The intervention that was tested here in this randomized control trial was a job accommodation, vocational counseling, education, and self-advocacy training. This was all, so all of these aspects of the intervention were given to the person in the intervention arm as a bundle, and they were compared to the people who did not receive that. And the control group here, they just received a written packet. They were mailed a packet that had different resource material for them about where they can access some of these, areas where they can get help, like in a format of brochures and just like velours, like in written format. And the people were followed up for 4 years. And this is considered the longest-lasting control trial for people with arthritis that tested an intervention of a non-pharmacological nature. So the intervention, or people who received the experimental intervention, that was delivered in 2 1.5-hour meetings that was conducted by a vocational rehabilitation counselor. Now, what the voc rehab counselor did was they assessed the problems the person had in the workplace, and they developed solutions of these problems. So, for instance, told them that I have an issue, for instance, with prolonged sitting periods of times. The voc rehab counselor gave them some solutions, and they encouraged the individual who has arthritis to come up with solutions with them. And there was also, during that meeting, there was promotion of the belief that that I can work, the person can work if problems do arise, and reassurance that the person does have the capacity to work and think through it. There's also the component of where the individual was given some insights and provision of information about their legal rights and what they are, what they can access in terms of policies. And there was also a discussion of the disclosure issues, which we mentioned earlier, that's a problem that persists some people who have arthritis in their employment settings. So there has the interventionists could have discussed different ways where they can discuss their issues with the participant, and maybe they could have done like role plays between the employer and the employee who has the issue, and so on. And another part of the intervention was giving some planning for future job and career change or advancement if the individual felt that that was not the best fit for them. And after the intervention, as you can see here in the chart, over 48 months, or 4 years as we have said, you can see in this chart here, the solid line is the intervention group, and they're the people who received the job retention program. And you can see that the odds ratio was 0.58. So people were 0.58 less likely to become work disabled if they had received the job retention program, as opposed to people who received the printed materials in the control group.
Thank you, Rawan, for that great background. So all of the background that Rawan has talked about and Dr. Alhere's study has led us to conduct a recent randomized control trial that I will talk about now. And it was a privilege to have Rawan work with me on this trial. The title of our trial was The Efficacy of a Work Disability Prevention Program for People with Arthritis and Musculoskeletal Conditions. We've kind of named that study the Work It study, and it was a randomized control trial. So our study aims were to examine whether participants who were randomized to a work disability prevention program had one, less work limitation over 2 years as compared to the controls, and that was our primary aim, and two, less unemployment over 2 years compared to controls, and that was our secondary aim. We identified unemployment as our secondary aim because of power and sample size considerations over a 2-year period. This was a 2-year randomized controlled trial. We enrolled participants between November 2001 and January 2004 from the greater Boston area, as well as central Massachusetts. And the trial was registered in the clinicaltrials.gov with a number on the slide. Eligibility criteria for the study were age 21 to 65, and people needed to report being employed at least 15 hours per week and working in Massachusetts. They also needed to self-report a doctor-diagnosed arthritis or rheumatological condition or chronic back pain. And they also needed to self-report a concern about their ability to stay employed in the near future due to their health. We looked at outcomes of work limitations and unemployment at 6, 12, and 24 months. And for work limitations, we ascertained that using the Work Limitations Questionnaire, the WLQ, and we used the Output Demands subscale, which ranged from 1 to 100. We also looked at permanent unemployment, and we defined that before we started the study as becoming unemployed during follow-up and remaining unemployed at the end of the 24-month self-report period. So this is just an example of the WLQ items that we included on our subscale, the output demand subscale. And that was for in the past 2 weeks, how much of the time did your physical health or any emotional problems make it difficult for you to handle the workload? And how much of the time did your physical health or any emotional problems make it difficult for you to work fast enough? There were 2 other items as well. Our intervention was similar to the Alheresh intervention. We did modify it slightly. The Alheresh earlier article or study that Rawan discussed was delivered by trained vocational rehabilitation counselors. We instead used trained physical and occupational therapists, feeling that physical and occupational therapists were also trained to deliver, had the background or the training to deliver such an intervention, and they may be able to interact with people and get to be people more in the preventive aspect of healthcare versus vocational rehab counseling, which sometimes intervenes mostly after people lose their job. So we did curtail the intervention slightly to really fit the PTs and OTs, which means we have focused a lot on accommodations. We did not do as much in terms of the vocational rehabilitation job counseling perspective. Instead, we referred that for vocational rehab counseling. But our intervention was a 1.5-hour program, and it was delivered by our trained therapist. We had 10 of them, spanning both occupational as well as physical therapy. And the intervention consisted of a barrier identification and problem solving and solution generating accommodation planning, some educational materials that were found in the resource packet that we provided, and I'm going to talk about all of that a little bit more in detail in a few minutes. And then we also had a follow-up phone call by our interventionist at 1 and 3 months. The control group then got a resource packet, the same resource packet that the intervention arm received. So for our interventionist, I want to discuss a little bit about our qualifications and training that we did, so you have a sense from that. For our expertise, we looked for people, therapists who were licensed and practicing. This was sort of a per diem job that could be done after work or on days that they may head off. They really only saw a few participants at a time, so it was not a full-time workload. So we wanted people who were licensed and practicing and active. They needed to have at least 2 years of clinical experience. We did prioritize expertise with arthritis or rheumatological clinical practice, as well as occupational health, but we defined that pretty broadly. We had hand therapists who were involved. We had people who specialized in geriatrics. What we really were looking for was for people who expressed and duly demonstrated a willingness to learn new treatments. So those people who were those lifelong learners, where they were active in their organizations and they were doing continuing ed, and they were always looking for learning new things. Karen, do I? Thank you. Our training session was really pretty nominal. We had 4 hours of in-person where we brought people in and went over some background about why we were doing the study, the issues of arthritis and work. We went over the intervention materials in depth with them. And then they had 4 hours of vignettes that they did on their own. And then we worked with them afterwards to kind of go over the solutions that they generated based on their working with the WES-RC. The WES-RC is one of the barrier identification tool that we used in the study, and I'm going to talk about that in a moment. And they also had some follow-up discussions about what solutions were generated. Okay. So then in details for our in-person meeting with the interventionist, they completed the work experience survey for people with rheumatological conditions, or the WES-RC. That involved identifying barriers and coming up with some solutions to those barriers, many of which involved around job accommodations or behavior change strategies. We had people identify an action plan, and it was a written action plan that the therapist received a copy of, as well as the participant. And the action plan was based on the discussion that the interventionist had with the participant, and largely based on the WES-RC. The interventionist also discussed the resource packet, and then they had a telephone call follow-up later at 3 weeks and 3 months to review the action plan. All right, so this is the work experience survey for people with rheumatic conditions. The survey itself is actually free to download, and we welcome you to download if you are interested. You can download it from our website. I'm going to give you a snapshot of what is involved in this WES-RC. It's a structured interview tool. Our therapist really appreciated the tool because it gave people lots of specifics, and it was easy to administrate and easy to use for discussion purposes. It includes a very comprehensive list of barriers for people with arthritis that we have shown in previous research to be important items for people with arthritis. It's a checklist format, so it's very simple to administer. It tends to be done in about 10 minutes, maybe 15 minutes. And it gives people this problem identification focus, and then we can discuss some problems for them. And then it's also leads you into a solution generation process. So section 1 is demographics and health and work history. And if you look at our demographics here, it's just the basic demographics. We do ask about education and type of employment, as well as degree of education. We get some information on their health history, what's their primary rheumatic condition, number of years with the condition, other health conditions, medications, etc. We also ask them about symptoms. Do they have pain, fatigue or low energy, changes in symptoms? Do they have difficulty sleeping? I don't have everything listed on these slides, but just a snapshot. So I want you to have a sense of what is on this, what the WES-RC involves or includes. And again, we go into work history, the number of jobs people currently hold. A lot of people with arthritis and chronic conditions have to work multiple jobs, thereby also making it very difficult for them to get the rest and the downtime that they need for their health. Whether they're self-employed, the title of their main job, the activities they do in the context of their main job, the hours at their work, number of years in main job, etc. We also ask about retirement issues, since early retirement and early job cessation can have an impact on retirement. So we do want to bring that into discussion if there are concerns. So we ask people, again, this is on this, they received this, it's a paper checklist tool. So the second section is where we start having them getting into the checklist format. Section 2 addresses getting ready for work and traveling to and from or for work. So a lot of times with arthritis, we're not just concerned about the hours that they are actually at the area or place of employment. But we really want to think about this from a 24/7 perspective, from the time they get up in the morning to the time that they go to bed and how well they're sleeping, because what happens in the morning can have an impact on what they're able to do when they arrive to work. So we ask people about getting ready for work, getting out of bed. Is there a problem? Is there a need for extra time for dressing or preparing breakfast, doing stairs? We have things such as if they're doing childcare or caring for their parents. We have traveling to and from work as another section, and some things, some examples that might be included in that are using public transportation, maybe driving. We ask them if it's difficulty or they have problems turning their head when they need to look in the rear. Do they have difficulty turning the key? Do they have difficulty or problems getting in and out of the car? And this is a checklist form. And then we ask them if they have any, so then they're asked to identify, let me go back for a second. So they are asked to put a check mark or an X or a check on anything that is a problem for them. And here you can see on this slide that this person has indicated using public transportation is a problem for them. They have difficulty walking or standing. Then we ask them at the bottom of each page if any of the items that they checked are a major problem for them. And if it is a major problem for them, we ask them to circle the item. And the reason that we do this is so that people can start identifying things that are a problem, but then identifying and prioritizing things that are a major problem for them. And then at the end of the instrument, then they go back and they choose from the items that they have circled, 3 that are the most important to address, and they will start working on them, things with them. So it's a nice, easy visual way to kind of get the snapshot of what's the most important things that people are dealing with in the context of their work. So I'm going to go over just some of the different domains that we have on the WES-RC. Section 3 covers workplace access. So again, we ask people to check the items that are sometimes or always a problem for you. So we have things such as getting into or around your place or your places of work, things related to parking, walking, climbing stairs, opening doors. We ask about door weight. We can ask about turning door knobs. We also ask about using workplace facilities, such as a toilet in the bathroom or faucets in the bathroom or even doors into people's offices, knowing that both kind of the physical components of walking and mobility, as well as the ability to use the upper extremity and hand in the context of work is equally important. So in section 4, we talk about some job demands or job activities that might have. So we ask people if there are any barriers in the context of physical job demands, such as standing or being on people's feet for too long, prolonged sitting, carrying things, or using a computer or other keyboard. Mental job demands, such as staying alert or sustaining attention, and things like memory, as well as focusing or concentrating on work activities. And then we also ask about time and energy and emotional job demands, such as working regular hours or extra overtime hours. So again, these are just snapshots, but you can see kind of the checklist format that we have for our different items and the different domains. In section 5, we have relationships with people at work. So for people who have arthritis and other chronic physically disabling conditions when they're working when they're employed, we know that coworker and relationships with their supervisors, as well as their relationships with people who are working for them, are really important in sustaining their ability to work. So we have several items that specifically address relationships with people at work. This first section is addressing supervisor or manager not being supportive, such as you're unable to explain your condition to your supervisor, you are treated differently or not in the way you want, you fear being thought of as of less value. And on many of these, we have an other box so that people can write in things that may be also going on. Then the next section we would be coworkers are not supportive, they don't help when you ask for it, you don't want, or are afraid to ask for help. We ask if people feel guilty about taking time off, and that coworkers resent you from taking time off. And again, these are all items that have been shown through our previous work to be important for people with arthritis. So Section 6 on the WES-RC is work conditions and company policies. For people with arthritis, lighting and sound can even be very important for people. So we ask about fluorescent lights, we ask about outdoor light, and if they have any sensitivity to sunlight or the fluorescent lights, and then again, if there are any other types of things that they have come in. Some people are very sensitive to odors and smells as well, so we have some of that on the checklist tool. And then we also ask about company policies. Do they need to arrive at a certain time? Are they allowed a certain amount of sick days? Do they have not enough flexibility in their job to meet their medical or health needs? Do they not have enough, or do they have not enough time to take rest breaks? So once they complete the WES-RC, again, they identify and they check, or they put a X next to any factor that's a problem. Then they go over and then they circle things that are a major problem for them. And then they scan the factors that are circled to be a major problem. And we ask them to identify 3 of the most bothersome problems or barriers to address to their current employment situation. We then ask the participant completing the form to have a discussion with the interventionist, and that discussion is very patient-centered. So we train the interventionist to really recognize that our participants come into the situation having a great deal of experience in dealing with arthritis. They have tried many things, and we really bring that experience first and foremost in so that we understand where they've been. And it's a very mutual problem-solving solution generation process. We did provide our interventionists with a solution manual because we did have previous research that showed that PTs and OTs felt that they would benefit from having some ideas to help with some of the solutions that were raised. So we did have a pretty in-depth solution manual for people that was put together by expert consultation. So just as an example of how someone might address this problem barrier situation, is these are just 3 things out of a list of probably 10. Most people check off numerous things that are problems for them. But for example, someone might have said that they had difficulty with prolonged standing, that they also may have had difficulty with carrying suitcases and equipment, or difficulty attending children's events after work due to fatigue. And these actually were taken right from someone's WES-RC. So this group here is a pretty common scenario. So if someone had prolonged standing, we would work with them on ways to either figure out how they could use a chair more. If they really needed to stand more, we might think about getting a stool, depending on what the job is or what the context is. But we really worked on how we can accommodate that and get that to work within the context of their individual situation. So I'm going to shift gears. So after that, then, now I'm going to shift gears a little bit. I'm going to talk about the resources that we provided them. And this is just a snapshot of the materials, the written materials that we have. Many of the written materials we have are available on our website, and they're available. We have many links to them, and you're available to download those resources for free. But we offered people or recommended people that they, look at the Job Accommodations Network, or JAN. And the Job Accommodations Network is wonderful. I would highly recommend it for people who are trying to figure out or thinking about some accommodations in the work context. They are really good at working with people and very helpful. People can call them or they can access them online. We also gave them some one-stop career centers information, which helped people if they did need a job change. We gave them information on the Americans with Disability Act and rights, and we discussed that with them. That was new for a lot of the participants in our study. We also gave them information on some of the foundations that are supporting people who have the conditions that we were treating. So the Arthritis Foundation, the Lupus Foundation, the Scleroderma Foundation, also those sorts of resources were provided for people. They also, in turn, have many resources for sustaining employment. And then we also specifically referred people to vocational rehabilitation services if needed. We did tell our interventionists, again, who were PTs and OTs, that we were not looking for direct referral to PT or OT treatment. If someone felt that this person absolutely needed it, they could make a referral, but that really didn't happen very much. We did have some people who referred to have people go see rheumatology if they felt that the condition was not fully medically managed, but most of our referrals were for vocational rehab services. So this is a diagram of our consort, of our enrollment and following our subjects through the study. This is our consort flow chart. We assessed 652 for eligibility. Most of those people actually were enrolled. We excluded 335. Most of that was for inclusion criteria not being met or just did not want to participate. We then enrolled 317. We found 13 people to be ineligible at baseline and were not randomized, and we were unable to contact 17 people after we enrolled them. So we randomized 287. We had 143 randomized to the intervention arm, and we had 144 randomized to the control arm, and then we followed people for 2 years. And we received follow-up on 125 people and 139 people. This comes to about 92% for follow-up for data, 2 years, which was very good. So our sample demographics here, we had our average age was about 50, and we had about 73% who were female, majority of people who were white, though we had almost a sizable number, about almost 30% of people who were non-white, and most of the people had a college or high school degree, so we have a fairly educated sample. I'm showing you here the differences between the control and the intervention, and we did not have any statistical difference between the two, which we would not expect because it was a randomized control trial and people were blocked on age and sex. Okay. So I'm going to give you a little bit of information about our work characteristics of our sample. Most of the people had one job, though I did say a sizable number of people who have arthritis have 2 jobs. Our average hours of work per week was 36. The days missed in the past 3 months was a little over 2. Our work limitations score was at 35. This showed some limitations at work. We had then pain, fatigue, and stress, and job satisfaction. These scores were a 0 to 10, and a score of 6 would show that there was moderate pain, and fatigue would also be a moderate pain at 6, and stress a moderate pain. And job satisfaction was pretty good. The 10 was high, so the satisfaction, even though they were facing work challenges, was actually pretty good. About 45% had management or professional and related occupations, about 23% had service occupations, and then about 22% had sales and office occupations. All right, so our results have been calculated. We have a paper under review, and so I would encourage you to stay tuned if you're interested in this topic, and we would love to be back and present our work with you if that opportunity was to come forward. But it is under review, so hopefully we'll have that out soon for you. So thank you.
Thank you, Julie and Rawan.
Thank you.
Thank you so much. This was so interesting. Now, we have some people on here, and I'd like to see if there's any questions that you might have from the people who are attending. Feel free to type them in, and I can make your mics live, but why don't we have you type them in? Are there any questions that you might have? Please feel free to type them in. So let me ask a question. What are you seeing as the future for ENACT, and where do you think research is going in this area?
I think that there is still a tremendous interest and need in employment research in arthritis and chronic musculoskeletal conditions. So I think that that is a very important area to to continue to do some work on. We know a lot of people who have arthritis and chronic musculoskeletal conditions lose their job at an increased rate to people who don't. We know meds do not. We know that problem still exists even though there are medications. I think the more that we find some positive interventions and approaches, the next step will be towards implementing those approaches in the context of the real world, such as, should we embed this sort of an intervention in the context of clinical care? Do we embed this in the context of employers? How best can we reach the people who really need this? So I think our next step really is going to be taking this into the real world context and seeing how we can get it to work.
Julie, great answer. And I love that this is an interprofessional initiative. Susan wrote, do you think this tool could be used for other conditions?
Yeah, it's a great question, Susan. The tool originally came from multiple sclerosis. It was called the Work Experience Survey, and it was done by Rossler for multiple sclerosis. Many of the items and the domains are similar that we use for our group. We have some things that are specific to arthritis, such as lighting, some of the lighting stuff, which may not be as relevant for multiple sclerosis. I think there are some items. A coworker support was also important for arthritis. So I think bottom line is yes, I think it can be used for other conditions, has been used for other conditions. I think depending on what that condition and that population is, it may need to be tweaked slightly just to make sure that we have the appropriate items that are relevant for that specific population. But I think the approach in terms of using a checklist to identify barriers, helping them problem solve and prioritize what is important, and then engage in a conversation of how are they going to start addressing those main problem areas, I think is something that's absolutely applicable across populations.
Great, that was a good question. And I am familiar with the original instrument. And that author actually publishes quite a bit of work.
Oh, good.
Thanks, Susan, for posting. Are there other questions? Please feel free to post them as well. So, Julie and Rawan, I was thinking about this as you were presenting. Were there any surprises that, were sort of unexpected in this whole process? And are there any lessons learned that you could share?
Rawan, do you want to start? I'd love to hear your thoughts.
Okay. So I think for me, I think what we learned throughout the process was that recruiting participants for this type of study was difficult. And we kind of learned as we went through the process of how we should change things, and so we can recruit the sample size that was required to get the significant levels that we were hoping for. So that was one of the things that we learned throughout the process. I don't know if you agree with me, Julie. And I think the part that I was really, not surprised, or I was really interested in hearing some of the experiences that the people, spoke about, because when I did the majority of the follow-up phone interviews with the participants, and we had a qualitative open-ended question towards the end of the questionnaires, and they always had some really interesting insights, and I didn't appreciate before how big of a problem this is for people who have arthritis, and people were very happy that there are researchers tackling this issue, and they encouraged us to do more of what we're doing. So that's something that I was, happy about.
Thanks, Rawan. Yeah, I would echo a lot of that, and then I'll expand on a couple. So as Rawan mentioned, recruitment was challenging. We aimed to recruit 350 people over 2 years, which is a lot for a randomized control trial. I was really surprised, and that was all from the greater Boston area. In hindsight, lesson learned, I would probably do a multi-site study because I think that you can recruit more easily over 2 sites in a shorter amount of time. But I was really surprised that we actually got 287 people from the greater Boston area recruiting through the community that expressed concerns about being able to work in the near future. And I didn't present this because our results are under review, but over the course of 2 years, 35 people in our study became unemployed, which is huge. So I think the notion that so many people were interested in this. We hit a pretty large sample, even though it was hard, and that we had a number of people who really did lose employment over 5 years was pretty good. We did not expect a lot of people to become unemployed, which is why we went over the which is why work limitation was our primary outcome. The other take home for me was we worked with 10 interventionists, both PTs and OTs. OTs loved the checklist tool, and they loved it because it was very comprehensive, and they felt that it really gave them a nice vehicle to have the conversations that they want to have for people who are in this situation. And they were very enthusiastic right from the get-go, which I sort of expected, sort of knowing how OT kind of works and practices. PTs, on the other hand, they were also really excited about it, which was good. I think the approach was sort of new to a lot of PTs, and they really embraced it, and they really liked it, and they equally did just as well in discussing with people about the solutions, and they were equally enthusiastic. So that was nice. That was good.
Great. I'll take that compliment for the OTs, and you can take it for the PTs. Thank you. So we're getting close to needing to wrap up. I want to thank people for being here today. And Rawan and Julie, is there anything else that you would like to share before we conclude this webinar? And I want to thank you so much for spending time with us and sharing your study and your expertise. You're really adding to the evidence literature and really making a difference for people being able to be employed.
Rawan, anything you want to add?
Not at this time, but I would like to encourage people to always search for evidence-based approaches. I wasn't really aware of such interventions before I started my PhD, and I did practice as an OT before, and I wasn't aware of the evidence-based, interventions that we can help. So I encourage people to search for that. If they ever need any, ideas, I'm sure there's something out there. That would be probably the message that I want to tell people.
Excellent. I guess I'll just really say thank you to Dr. Jacobs for the work that she does with this journal. I think it's a really important area that we move the science forward from science to clinical practice. And it's in large part from people like her that we can make the gains that we can in the field. So I guess that my support would go to you for the work that you do.
Thank you so much, Julie. That was really very, very kind of you. So everybody who's joined us, I hope you enjoyed this Learn at Work webinar. Our webinar series will continue in 2006 on December 8th from 1 to 2 p.m. Eastern Standard Time. Tan Albin will discuss computer ergonomics, state of the art. I hope you'll join us. Please subscribe to the Learn at Work YouTube channel where you can keep up to date on what we're doing. And Julie and Rawan's YouTube, their presentation today will go on YouTube so you can listen to it again. We're putting together the 2017 series, and I welcome hearing from you on what journal article you would welcome hearing the authors discuss. In 2017, we're going to have the Learn at Work webinar series on a monthly basis. So we hope again you'll join us. So thank you again, and Julie and Rawan, thank you so much.
Thank you.